In the next few minutes, I would like to talk on approach to spondyloarthropathy, a clinical insight, differential diagnosis, and evidence-based medicine. It's a chronic disease. It's an immune-mediated inflammatory disorder, and a strong genetic predisposition is there. It runs in the families, HLA-B27 positivity, and the key pathology here, the enthesitis and dactylitis. This is the very important landmark, feature of all your spondyloarthritis is the enthesitis and dactylitis. What you mean by enthesitis? That is the inflammation of your ligaments or the tendons or the bone capsules attaching to the bones. That is the enthesitis. That is the most characteristic feature of your spondyloarthropathy. It's a shared clinical features across the subtypes. It's very difficult to differentiate different spondyloarthropathies. You have the 5 types of the spondyloarthropathies. One is ankylosing spondylitis. The second one is psoriatic arthritis. The third one is arthritis due to IBD, that is inflammatory bowel disease, either Crohn's or the ulcerative colitis. And the fourth one is reactive arthritis. And the fifth one is undifferentiated spondyloarthritis. This is the spectrum, axial spondyloarthritis, involvement of your mostly the spinal joints, especially your lumbar spines, thoracic spines, etc. Maybe the entire spine will be involved here, and sacroiliac joints. And the peripheral spondyloarthritis, there will be the involvement of the different joints like the hip joints. As I told you that the enthesitis and the dactylitis, sausage-shaped digits, sausage-shaped toes, that is your dactylitis. Mixed forms, both the axial and the peripheral, that's very common in our clinical practice. So you can see the involvement of the spine, sacroiliac joints, hip joints, and also the enthesitis and the dactylitis of the toes and the fingers. Extra musculoskeletal manifestations are very, very common in the spondyloarthritis. That is the reason sometimes you get the referrals from the ophthalmology friends saying that this fellow is infected with uveitis or episcleritis, etc. So please rule out autoimmune disease, or please rule out connective tissue disorder, or please rule out any genetic disorder in this patient. So that's how we get the referrals from our ophthalmology friends because of this uveitis. The same thing happens to the dermatology friends. They send a lot of the cases to psoriatic arthritis. Okay, so inflammatory bowel disease from the gastrointestinal point of view. So this is the classification of the spondyloarthritis, the predominantly axial. It is ankylosing spondylitis, radiographic and non-radiographic. What you mean by radiographic and non-radiographic? Radiographic, where your X-rays will show you the abnormalities. Simple X-rays, conventional X-rays. Non-radiographic means your MRI will show the defects. So the most earliest one will be picked by the MRI. At a later time will be picked by the conventional X-rays. So don't wait to see the changes in the normal X-rays. You have to suspect ankylosing spondylitis or other spondyloarthritis before your conventional radiology picks up the salient features. So you have to advise the MRI much before your conventional X-rays to know the defects there. That shows the MRI which shows the edema. I will show you the pictures at a later time. So that's how we have to differentiate these ankylosing spondylitis, radiographic and non-radiographic. Predominantly peripheral is the psoriatic arthritis, mostly the distal interphalangeal joints, your nerves involvement, your skin involvement. Reactive arthritis may be following your urethritis, conjunctivitis, raters, etc. And IBD associated arthritis. Nowadays we are also seeing a lot of IBD associated arthritis because of the increased incidence of your Crohn's and ulcerative colitis in the society because of the high intake of the westernized food. And undifferentiated in the juvenile spondyloarthritis, they are not that common, but sometimes we happen to see such cases, especially in the children. So ankylosing spondylitis, also called as AS, not your aortic stenosis here. Aortic stenosis is we are not seeing much aortic stenosis nowadays, but we are seeing more and more ankylosing spondylitis nowadays. It's a chronic and immune-mediated disease, affects the skeleton, axial skeleton, leads to the chronic pain, stiffness, and the fusion. So this is the landmark symptoms in ankylosing spondylitis. So these people will have the inflammatory backache more than the 3 weeks or more than the 3 months, and the back will be the stiff, not only your lumbar spine, thoracic spine, etc., and also there will be the fusion and leads to the bamboo spine and etc. Radiographic sacroiliitis is the hallmark. If you see an MRI, So that shows a beautiful edema over the joints there, sacroiliac joints. That is the most earliest manifestation you often see in MRIs. Male and the female, so it is one of the few arthritis more common in the males when compared to the females. Most of the arthritis are very, very common in the females when compared to the males, but ankylosing spondylitis is one exclusion where more you can see in the males rather than the females. HLA-B27 positivity in about 90% of the cases, and at the same time, maybe 8 to 9% it may be positive even the normal individuals also. So HLA-B27 positivity doesn't mean that this patient is suffering with ankylosing spondylitis. It has a high predictive value to know that this fellow, anyone presented with inflammatory backache with HLA-B27 positivity could be ankylosing spondylitis. So this is the earliest stage, non-radiographic. Already I told you, changes visible on MRI, not an X-ray. If you see the X-ray changes, then it is a radiographic axial spondyloarthropathy. May progress to ankylosing spondylitis over that time. More common in the females here. Same clinical features as ankylosing spondylitis and equally impaired quality of death. This is the very important point in ankylosing spondylitis and other spondyloarthritis. Why we give a lot of importance to the diagnosis? Early diagnosis of this spondyloarthritis is quality of the life. So these people will be having the more inflammatory pains, breast pains, nocturnal pains. So obviously they skip the duties. So that is how the quality of the life will be impaired. More of the morbidity rather than the mortality here. This is the psoriatic arthritis. You all appreciate here. This is a sausage-shaped disease and also the penicillin cup. See the nails here, the distal interphalangeal joints and also the nails. Associated with the psoriasis, both the skin and the nail changes, asymmetric oligoarthritis, dactylitis, I already told you the sausage digit, highly characteristic. So diffuse enlargement of the toes. Enthesitis, the Achilles tendon, plantar fasciitis, etc. Axial involvement in about the 40% of the cases in psoriatic arthritis. This is the reactive and also the inflammatory bowel diseases. So reactive arthritis triggers mostly following your gastroenteritis, following the viral infections, etc. Your Shigella, Salmonellosis, chlamydia. Classic triad is arthritis, urethritis and conjunctivitis. IBD, so Crohn's and ulcerative colitis is mostly the peripheral arthritis, and also the axial involvement is also will be involved in some cases. See here the nail psoriasis. A thickening and crumbling of the nail plates, thickening and crumbling of the nail grade toe, pitting and onycholysis. What is mean by onycholysis? Elevation of your nail. They are visible on the right side, suggesting the nail psoriasis as the diagnosis one. So these are the spotters to define a psoriatic arthritis. Unless you see the skin and the nails, you will definitely miss the psoriatic arthritis. Epidemiology of the spondyloarthritis prevalence is very, very high. 0.5 to 1.5 is not a small one. It's a very big disease of the general population. And luckily, South Asians 2 to 4% when compared to the Europeans, where 8% is very common there. But what is more important here is the onset of the disease. It's not a disease of the elderly, but a disease of young adulthoods. In the second decade, third decade, and the fourth decade. So the mean diagnostic delay is 7 to 10 years. So this is the very worrisome point, because most of the people with the backache, they go to the orthopedic surgeons. So they get the X-rays done, they get the MRI done. They thought that it is because of the mechanical pain, or they may be because of the disc prolapse and etc. So until they diagnose a spondyloarthritis, the delay is about 7 to 10 years. So that is how these ankylosing spondylitis people, they present with not only the musculoskeletal but all the extra musculoskeletal manifestations, uveitis, etc. Some people, they may present with heart blocks. Some people, they present with premature atherosclerosis, myocardial infarctions, etc. So don't delay the diagnosis. So unless you don't know the spondyloarthritis, definitely you are going to delay the disease. So once you know that, so definitely you can pick up the spondyloarthritis but early, so to give him a good quality of the life. What about the disease burden and the impact? It's a chronic pain and the stiffness. So obviously the reduced physical function. Work disability is about 30 to 40% of the population. Reduced quality of the life compared to the other chronic diseases, because the movement is restrictive. So because of the restrictive movements, they want to take rest, much bed rest. So that obviously the quality of the life will be disturbed, because the life is mobility. Here the mobility is compromised. Psychological impact will be high because of the depression, because of the anxiety, and also the high economic burden, either direct or the indirect cause. So why this is underdiagnosed? So back pain is ubiquitous. So everyone says the back pain. So the back pain is a very common symptom. So you need not give much importance to the back pain. So that's almost the people, they say that it is a mechanical pain, take rest or take some antacids, NSAIDs, etc. Lack of awareness among the physicians or the clinicians or primary doctors. So this is a very important point in the Indian population, because rheumatology was not taught in undergraduation. Even in the post-graduation also rheumatology was very less taught. But once you are outside the hospital, the most common symptom anyone presents to a doctor is pain. So most of the times, your examination cases, almost I can say them, they are the dustbin cases. You see a lot of the choreas, you see the CVAs, you see the bronchiectasis, you see the cirrhosis of the liver or the ascites, etc. What they put in your examinations in your undergraduate or in the post-graduation, long cases or short cases, they are not of much use in our clinical practice. So whether it is mid-diastolic murmur or early diastolic murmur or early systolic murmur, a murmur of the grade, or increase in the respiration, or decrease in the expiration, or left lying position, or the sitting position, or stooping forward, everything we don't give much importance to the clinical medicine. Just we send it for 2D echo. And the report says that MS mild or MS moderate or MS severe, or with or without MR, or with or without other valvular diseases, everything can be seen within a half minute or the 1 minute. So you don't require much attention to these valvular diseases, but unfortunately even those cases were put in our examination halls. But this rheumatology is a very, very important in the clinical practice. See, the immunology of the spondyloarthritis is autoimmunity versus the classical autoimmune. Yes. So you have a lot of the antibodies there, the double stranded DNA, RNP, okay. So they are negative here, the spondyloarthritis. The key cytokines here is the tumor necrosis factor and interleukins. This is very important because you have the drugs, the biological drugs, which acts against the tumor necrosis factor like etanercept, adalimumab, rituximab. In the same way, you have the interleukin 17 antagonist drugs also, they are the biologicals. So they are very useful. IL-17 inhibiting biologicals will be very useful in psoriatic arthritis, whereas the tumor necrosis factor alpha, TNF alpha biologicals are very useful in ankylosing spondylitis. So your diagnosis, once you come to a reasonable diagnosis, then you can pick up the biological of drugs of the choice. See, the enthesitis is driven by the IL-17 producing the cells. Gut microbiome is the emerging role. Now every disease is associated with the gut microbiome, your probiotics, your prebiotics. Okay, so now it's a big chapter, the dysbiosis, gut dysbiosis. So where the amount of the good bacteria at the lower level, whereas the amount of the harmful bacteria at a higher level, that is our dysbiosis. That is also very emerging risk factor for most of the diseases, including our diabetes, hypertension, ischemic heart, even for the malignancies. So now the origin is in the gut microbiome. So that is the reason now the gut is considered as our second brain. So gut contains a lot of the neurological interventions and releases a lot of the hormones, etc. HLA-B27 is the major genetic factor. The presence in about 90% of ankylosing spondylitis versus 8% of the general population. So being positive, HLA-B27 positive doesn't mean that the patient is having the disease, like your Manto's positivity. So Manto positivity doesn't mean that he is suffering with the tuberculosis, he is exposed to the tuberculosis. Okay. So strongest genetic association in the rheumatology is the HLA-B27. There the different subtypes are there. Some are protective, some are disease causative, and not sufficient to cause the disease. It is mostly environment needed. That is the reason even though 8% of the people are having HLA-B27, they are normal because they are not exposed to the environmental factors. So these are the environmental factors. Your smoking will cause ankylosing spondylitis in the people with HLA-B27 positivity. Your viral infections, they may cause, your bacterial infections may cause, even your mechanical stress, That also may cause, may aggravate in HLB27 people to get ankylosing spondylitis. See, the gut microbiome dysbiosis is also one of the genetic and one of the environmental factors to cause the ankylosing spondylitis. What you mean by the enthesis organ concept? See, the enthesis organ is nothing but a combination of the enthesis, that is your tendons, your ligaments, etc., and the bone and bone capsule and synovium and finally the bursa. So what are all the structures other than your joint is enthesis organ. So the mechanical stress will lead to the micro damage, and that may be giving a route for your inflammation. And these inflammations are mostly interleukin 23 and 17 drive inflammations. Newborn formation, syndesmophytes, and then the ankylosis. This is a very common in ankylosing spondylitis. So there will be the ankylosis of all the joints will be there. So you call it as bamboo spine. So this is the very important cardinal feature of your ankylosing spondylitis is the backache. Which backache? Inflammatory backache. So this is the very important. Inflammatory versus non-inflammatory. Here the onset before the age 40. So in India we see like 20, 25, 30 also. It is insidious onset, the gradual onset. Improves with exercise, not with the rest. So any backache which is reducing with the rest, that means it's the mechanical backache. Increasing on the rest, it is an inflammatory backache. Pain at the night, especially the second half, maybe 2 a.m., 3 a.m., 4 a.m. with early morning stiffness, a mostly inflammatory backache. Morning stiffness more than 30 minutes and duration more than 3 months. Now the differences between the mechanical and the inflammatory backaches. Onset is acute in mechanical, whereas insidious and inflammatory. Age, mechanical, mostly any age group, mostly the elderly. Here the inflammatory, mostly the young adults, maybe second, third and the fourth decades. Exercise worsens in the mechanical, whereas exercise improves in the inflammatory arthritis. Rest worsens in the inflammatory arthritis and improves in the mechanical arthritis. Night pains are more inflammatory, especially the second half, whereas the mechanical no night pains because they is taking the rest. Morning stiffness more than 30 minutes in inflammatory, less than 30 minutes, maybe 5 to 10 minutes in mechanical. Nascead response, excellent in inflammatory arthritis, but variable in mechanical arthritis. That is the reason whatever tons of the nasceads you give it in disc or the lumbar spondylosis, not of much use. Sacroiliac joint pains is the deep buttock pains, it alternating. Spinal stiffness, the loss of the lordosis, reduced expansion. Limited mobility is Carber's test, less than 5 centimeters increase. Chest expansion is also reduced because of the costochondrial involvement, costovertebral involvement, they will be fused. Occiput to wall distance is also increased, so they can't touch the wall with the occiput because of the ankylosing spondylitis, because of the less lumbar lordosis and more kyphosis, they droop forward, so there will be a big difference, distance between your occiput and the wall. So that is occiput to wall distance will be increased, and cervical spine involvement is a late feature. Earlier is a thoracic spine, lumbar spines, sacral spines, and lastly the cervical spine. Here one DD here is the rheumatoid arthritis. Rheumatoid arthritis never involves the spine except the cervical spine. The peripheral arthritis is mostly asymmetric, oligo-articular, large joints in the hips, knees and the ankles, small joints, hands and the feet, especially the psoriatic arthritis. I have shown you the picture, psoriatic arthritis. The common involvement here is the distal interphalangeal joints and the nails. Dactylitis is nothing but a sausage digit, highly specific one. Once you see the dactylitis, so that is almost like a spotter or a diagnosis that this fellow must be having spondyloarthropathy. Spondyloarthropathy. Hip involvement is a poor prognostic factor. Most of the people now, thanks to the good orthopedic surgeons, because a lot of the people earlier, they used to live without any hip replacements. Now, when the fellow is having any hip replacements, it's a life you will be very, very happy. So the now hip replacements are very common, knee replacements are common, shoulder replacements are also very common because of these diseases picking up at an early stage. So enthesitis is the hallmark lesion of the spondyloarthritis. The common sites, Achilles tendon insertion, plantar fascia, heel pain. Mostly after taking the rest, once you touch the ground after this class, you will get the pain by touching in the floor. So that is your heel pain or Achilles tendon pains. So that shows your enthesitis. Okay. So the patellar tendon pains, and iliac crest, costochondral junctions. So that is the reason the reduced chest expansion because of this costochondral junctional involvements. There will be the localized tenderness, localized swelling. Maybe the only the manifestation is the enthesitis. So you should give a lot of respect to the enthesitis in all spondyloarthritis individuals. That may be the only manifestation. So extra-articular, so the medicine is your general medicine is also called as internal medicine. So here in rheumatology, so this internal medicine plays a major role because extra-articular manifestations. So most common extra musculoskeletal manifestations in ankylosing spondylitis, about the 20 to 20% of the cases is the uveitis, usually unilateral, sometimes recurrent, symptoms red eye, pain, photophobia, blurring of the vision. So they reach ophthalmologist. Now the ophthalmologist is referring this case to you to decide whether this fellow is having any underlying autoimmune disease or underlying ankylosing spondylitis, etc. So urgent ophthalmology referral. HLA-B13 positive patients the highest risk, and the TNF inhibitors may reduce the recurrence. So here in such patients, in anterior uveitis or psoriatic arthritis, etc. So don't be happy with your sulfasalazine or leflunomide or methotrexate or hydroxychloroquine. These are your classical DMRDs, what we use in our clinical practice. You have to upgrade your medications in these spondyloarthritis by using your biologicals, especially your etanercept, adalimumab, etc. So these inhibitors may reduce the recurrence of your anterior uveitis also. Psoriasis and IBD, yes, in about 10 to 25% of the cases you have the extra-articular manifestations. The scalp psoriasis is common, elbows, knees, umbilicus. So that is the reason some people know they don't know that they are having the scalp psoriasis unless you see and diagnose it. In the same way, some people they don't know that they are having the psoriasis in the palmar areas, in the plantar areas. Nail pitting, onycholysis. So IBD Crohn's is more common than the ulcerative colitis as far as this spondyloarthritis is concerned. Sometimes maybe the subclinical, they may not appreciate these diseases. See the nail psoriasis with the pitting and the discoloration, irregular pits and areas of yellow-brown discoloration, the oily spots in a person with the psoriasis. Cardiovascular, I told you that aortitis and aortic regurgitation is the very common. Here, the conduction defects, heart blocks are also very common, and there is a people with increased atherosclerosis. So atherosclerosis starts from our birth, and atherosclerosis increases in the people with ankylosing spondylitis and other spondyloarthritis individuals. So in pulmonary, we discussed about the cardiac ways, aortic regurgitation, your blocks and your premature atherosclerosis and ischemic heart diseases, etc. Restrictive lung disease in pulmonary, renal, IgA nephropathy, neurological cardiac vena syndromes. These are the red flags. So when to suspect spondyloarthritis? So it's very important to diagnose the spondyloarthritis because you are reducing the mobility, you are improving the mobility, and you are reducing the morbidity, and also you are reducing the extra musculoskeletal manifestations by proper diagnosis. So any chronic backache more than 3 months, onset less than 45 years of the age group, plus 4 of these factors. Onset before the age 35, insidious onset, improves with the exercise, no improvement with the rest pains are there, night pains are there, improvement on getting up, HLA-B27 positivity, and strong family history of the spondyloarthritis and extra musculoskeletal manifestations like anterior uveitis, etc. So if you see such cases in your clinical practice, so please suspect spondyloarthritis. So this is the diagnostic algorithm. So clinical history is important, examination is important, lab investigation is very few. ESR, CRP, HLA-B27 sufficient. Imaging, so early stages MRA, at a later stages established cases, even X-rays also will help you. This is ASAS classification criteria, that is the International Society of Ankylosing Spondylitis criteria. So history taking, key questions, when did it start? How did it start? Is it gradual or insidious? What makes it better or the worse? Is it exercise improves or increases? Do you wake up at the night with the pain, especially the second half of the sleep patterns? How long is the morning stiffness? Any joint swellings or heel pains or enthesitis, etc. Any red eye, skin rash or bowel symptoms to rule out your ankylosing spondylitis or psoriasis or inflammatory bowel diseases, etc. Is there any family history? Because it runs HLA-B27, runs in families. Examination, inspection, posture, loss of the lordosis, kyphosis, Scarber's test, lateral spinal flexion, chest expansion is reduced, occiput to wall distance is increased, and SI tenderness, sacroiliac tenderness, is a palpation, compression, a Faber test. So joints, the swelling, tenderness, dactylitis, swelling of the entire digit, enthesitis, Achilles, plantar and patellar, psoriasis, skin, scalp, elbows, knees, nails, pitting, onycholysis, oil drop, eyes, redness. ESR and CRP usually elevated. It can be normal in some cases. HLA-B27 usually positive 90% of the cases. Rheumatoid factor anti-CCP, they will be the negative, that is the seronegative. And other things common is the anemia and sometimes the baseline renal functions and lung functions are important. So this criteria for patients with more than 3 months backache and age less than the 45, imaging the arm, sacroiliitis and the X-rays of the MRI plus one feature of your spondyloarthropathy. Whereas in the clinical arm, HLA-B27 positive with the two spondyloarthritis features. So what are their spondyloarthritis features? Your IBP, inflammatory back pain, arthritis, enthesitis, dactylitis, and uveitis, psoriasis, etc. So it is not that difficulty to diagnose ankylosing spondylitis. If you know these features, definitely from tomorrow onwards, you can definitely diagnose the ankylosing spondylitis or spondyloarthropathies. So diagnostic approach, step 1, low back pain more than 3 months. No, evaluate as a mechanical pain. Yes, go to the step 2. So it's inflammatory backache, more than the 3 months duration. Clinical spondyloarthritis features. Other causes. No other causes. Where the other causes are like your inflammatory or your psoriasis, your nail changes, etc. And then the X-rays. Is a positive ankylosing spondylitis. Negative, so don't be happy with the conventional X-rays. So it will take some more time. So when the conventional X-ray says the normal, so definitely go for MRI. Okay. So if MRI is positive, that is non-radiographic ankylosing spondylitis or spondyloarthropathy. See the clinical pictures here. See the radiograph here. So this is see here, your MRI. So these brain spots, this shows the tissue edema. So same time shows the multiple bone marrow lesions which appear as the edema. These are the bright areas. So these are the bright area. These are the bright area. This is the bright area. So this shows the brain edema. So that shows your ankylosing spondylitis, sacroiliitis. See here the spine, extra bone, bright weight. So these are the extra bones. See the bright one. These are the extra bone formation between the vertebrae. In places, this fusion is complete, giving the appearance of the bamboo spine. So once this fusion is completed, then it comes considered as a bamboo spine because of the thickening of these things. So imaging is the cornerstone of the diagnosis. So first line, these are the different grades are there. MRI is a preferable. CT is more sensitive but higher radiation when compared to the MRI, and ultrasound we don't use them. These are the X-ray findings in the sacroiliitis, the early, established and the late. In the early, the joint space widening and the blurring. Whereas in the late stage, the joint space narrowing and ankylosis. In the established one, there will be the erosions and there will be the sclerosis on the iliac side. So they have the different grading as per the X-rays is concerned. So grade 0 to grade 4. So the 4 is the ankylosis and 0 is the normal one. So MRI findings is the acute is the chronic. In acute you will have the edema. I showed you the picture there, the brightness of the bones. And you will have the synovitis, enthesitis and the capsulitis in the acute. In the chronic, you will have the fat metaplasia, erosions, sclerosis and mostly the ankylosis. MRI of the spine in the spondyloarthritis, the spine involvement is about 75%. Active is a corner lesion, they are the shiny corners. In the chronic one, syndesmophytes and the bamboo spine. Syndesmophytes nothing but your new bone formation. So that white lines between the vertebrae, that is the syndesmophytes. Anderson lesions is the pseudoarthrosis. So MRI is superior to the X-rays for the early spinal inflammation. Imaging algorithm, high suspicion, classic symptoms, X-rays. X-rays are negative, then go for the MRI. If X-rays are positive, MRI spine and the sacroiliac as a baseline. Monitoring the response, MRI if available, and peripheral joints, take it an X-ray or the ultrasound. Differential diagnosis of your axial symptoms. So the mechanical low back pain is the most common, your discitis, etc., or your lumbar spondylosis. DISH is a non-inflammatory one, mostly the elderly individuals. Osteoarthritis of the spine, alkaptonuria, infectious spondylodiscitis, mostly in the calves, fibromyalgia, and referred pain. So among the differential diagnosis, we often see the mechanical low back pain, osteoarthritis of the spine, sometimes tuberculosis. So part spine, that is also very common in our practice. So these are the mimics of the spondyloarthritis, the clinical approach. Always consider the mechanical causes is the most common one. Older individuals consider the DISH. Infectious sacroiliitis, unilateral and in evening rise of the temperature, etc., like that tuberculosis. So your mantos will be the positive, or quantiferon gold will be the positive, etc. In the malignancy, sometimes in multiple myeloma or leukemia or lymphomas. So there also you will have the spondyloarthritis picture like the backache. And Paget's disease, here the elevated alkaline phosphatase will be seen. So in the clinical context, plus your imaging and your lab will clarify that a positive diagnosis of your spondyloarthritis. Now coming to the treatment goals. So the ultimate first goal should be the relief of the pain and the stiffness. That is what the patient comes to you. So you want the symptomatic relief, and then relieve the pain and the stiffness. Control the further inflammation in the joints, prevent the disease progression, because if you don't prevent the progression, so there will be the ankylosing and the bamboo spines and the limited motions, etc. Maintain the function and the quality of the life. Minimize the treatment related toxicity once you use the biologicals or your methotrexate or sulfasalazine, etc. So there will be the drug induced toxicity will be there. So you have to minimize it and treat the comorbidities, and the goal is always remission or the low disease activity. So once the disease is the spondyloarthritis, so obviously the treatment should be lifelong, like your diabetes or hypertension, etc. So our goal is to make them in a remission as long as possible or low disease activity. So how can you know the low disease activity? Your CRP will be at a lower level, your ESR will be at a lower level, etc. That's how the low disease activity. Otherwise the ESR will be higher and CRP will be the higher. These are the non-pharmacological management. The patient education is very important. The self-management. Physiotherapy is very, very important in ankylosing spondylitis. So your stretching, your postural or breathing exercise, etc. Regular exercise, especially the swimming and the walking, they're better. And smoking cessation is very, very important. And maybe the psychological support is also equally important. They are the non-pharmacological management. Rehabilitation, yes. Pharmacological management. Now moving to the step 1 is the NASIADs. The step 2, if inadequate, so go for the biologicals or tissue specific, maybe your JAK inhibitors. If inadequate, switch to the mechanism. So this is the conventional synthetic DMRDs like your methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. They are not recommended for the pure axial disease. That is the most important take home point. So once the diagnosis is your spondyloarthritis, spondyloarthropathy, so better not to use the conventional synthetic DMRDs. They are not recommended for the pure axial disease, maybe for the peripheral arthritis, not for your spinal diseases, etc. For spinal, usually you go for the biologicals like your rituximab, etanercept or adalimumab, or your JAK inhibitors like tifusitinib, that is your tissue specific DMRDs. NASIADs are the first line, highest tolerated dose for the symptomatic axial. Some people they respond to the diclofenac, some people they respond to the indomethacin, some people they may respond to the ketorolac. So we don't know that. So no drug is common for all the individuals. That is mostly the individualized. Some people, after giving lot of the NSAIDs, they are not at all happy. But once you start them on the paracetamol, they will be very happy. So that means the paracetamol is ideal for them. So that is also there. So highest tolerated dose you have to give to reduce the pain and the stiffness. Response is often dramatic in the early stages, but later again not that much dramatic. Assess the response at about 2 to 4 weeks, not every day. So you should give the consultations maybe once in 15 days or once in a month initial days, and later maybe once in 3 months or once in 6 months. So concerns gastrointestinal, because these drugs will cause NSAIDs especially, they cause the gastrointestinal side effects like nausea, vomitings or gastritis, etc. And the renal, IgA nephropathy or NSAID induced nephropathies, and cardiovascular, yes. So because some of the NSAIDs, they regain the water, so then they may precipitate heart failures. COX-2 selectives, if the GI risk. So we use a lot of the celecoxib, 100 milligrams, 200 milligrams, that is our favorite drug, celecoxib. So that with very least GI risk. On demand versus the continuous debate ongoing. So most of the people they are happy in the NSAIDs. They keep on taking the NSAID until they get the gastrointestinal or the renal side effects. So you have to tell to the patient that these NSAIDs are for the only short-term gains. So don't use them for the longer period. Longer period, your biologicals only, or the tissue-specific DMR, because it is an autoimmune disease, because it is a systemic disease, because it will have lot of extra musculoskeletal manifestations. So you have to treat them. The extent of the disease is not treated by the NSAIDs alone. NSAIDs only painkillers. They relieve the pain and the stiffness only, not the disease. So NSAIDs role in the management of the spondyloarthritis only 15 to 20% symptomatic relief. These are the good drugs, biological DMRDs. Okay, TNF inhibitors, active spondyloarthritis despite the NSAIDs. Indication, yes, adalimumab, it is available 40 milligrams, we give once in 15 days. We also have the infliximab, that is also available, we give once in a week or once in 15 days or once in 20 days or once in a month or once in 2 to 3 months. Etanercept, these are very useful drugs. Also effective with the peripheral arthritis and enthesitis, preferred in inflammatory bowel disease associated spondyloarthritis and the uveitis, mostly these things. Monitoring is very important because we have to rule out the tuberculosis. Some people know they may be having the reactive or latent tuberculosis. That is the reason before you start the biological DMRDs, before you start these drugs, the 3 investigations are very must. One is the Manto, the second one is the CT chest, and the third one is quantiferon gold. So if the Manto is positive, if the quantiferon gold is positive, so that means the patient is having a latent tuberculosis. If you start using these drugs, so that tuberculosis will aggravate. So that is the reason we don't treat the patients with Manto positivity or quantiferon gold positivity, or your CT chest shows a COX lesions, we don't treat them with biological DMRDs. Straight away we go with the ATT for the first 2 months or the 3 months, they will subside that ATT and then we start using these drugs. So this is a very important take home point, that monitoring is very important. Don't start on the day 1, wait to rule out the tuberculosis. In the same way, we rule out the viral markers also. We also get the viral markers, hepatitis B, hepatitis C and HIV positivity. If they are the positive, again you go for the viral loads. When the viral loads are very, very high, we have to treat them with the antiviral drugs, and then only you start these drugs. I think I stop here. The biological DMRD, interleukin 17 inhibitors is the psoriatic. This point I already told you. The severe psoriatic arthritis, we prefer the interleukin 17 inhibitor, whereas the TNF alpha we prefer in ankylosing spondylitis. Now this is the very important drug, JAK inhibitors. They are available in the market, tofacitinib. So the 5 milligrams. This is also available in the market, opadacitinib. So this is also available. They block the JAK-STAT pathway. So in the immune pathology, so they inhibit the JAK pathways. So that's how they prevent this autoimmune extension of these diseases. So indication is active disease, despite the NSAID therapy. Oral administration is preferable, so they are available as oral forms. So again the monitoring is very important. So all these drugs we monitor at least once in 3 months or once in 6 months with the complete blood picture, with LFT, with RFT. Steroids limited role. Don't use the steroids for the prolonged periods in ankylosing spondylitis, etc. But people will be very comfortable with the steroids because the cheap available everywhere. So you can use the local injections of your steroids available in 40 milligrams, triamcinolone or methylprednisolone for an isolated sacroiliitis or enthesitis not responding to the NSAIDs and peripheral monoarthritis. So systemic discouraged long term. Limited efficacy for the axial symptoms and significant side effects of the long-term steroid therapy, maybe your diabetes, your hypertension, etc. So the conventional synthetic, when to use these drugs, not effective for the pure axial disc, but these are the drugs of the choice in rheumatoid arthritis. In rheumatoid arthritis, even today, the methotrexate is the treatment of the choice all over the world. So use a lot of these methotrexate, leflunomide in rheumatoid arthritis, but not in ankylosing spondylitis or spondyloarthritis. They are not that effective. May be useful for peripheral arthritis, in psoriatic arthritis, or peripheral arthritis in inflammatory bowel diseases. Sulfasalazine for the peripheral arthropathy. Our favorite DMRD in ankylosing spondylitis is the sulfasalazine. Okay, so we start with the 500 milligrams OD. And then you can slowly uptitrate to 5 milligrams BD, 500 milligrams TAD. Now 1 gram is also available as the BD or the TAD. So the maximum is the 3 grams for the peripheral arthropathy. Do not use routinely for axial spondyloarthritis without the peripheral involvement. So in women, yes. Juvenile, yes. Prognosis, poor prognostic factors. What are they? Hip involvement. So they are not able to walk properly because of the hip involvement. So go for hip arthroplasty. Early onset of the disease, 20 years, 25 years. So definitely poor prognosis. Persistently elevated CRP. Instead of your adalimumab injections or instead of your JAK inhibitors therapy, instead of your sulfasalazine therapy, etc. Still elevated CRP means the disease is very aggressive and more prognosis. Smoking, bad. Male sex, that is also more of poor prognostic factor. Mortality is slightly increased because of early CV and early renal, IgA nephropathy, and early diagnosis and treatment improves the outcomes. So what is more important in these diseases is your early diagnosis and early treatment improves the outcomes. Monitoring, treatment tapering. So these are the 10 commandments in the TEEP case. Think spondyloarthritis in young adults, especially the male, with chronic inflammatory back pain. Ask about the inflammatory back pain features, extra musculoskeletal manifestations, family history. Examine the spine. So don't stop there. You please emphasize joints, skin, and nails also. X-rays first, but MRI is the key for the early diagnosis. HLB27 is helpful, but not the diagnostic. NSAIDs are very useful in the first line, but don't depend on them. Chronic therapy. Biologicals are very, very good. Tumor necrosis factor in ankylosing spondylitis or IL-17 inhibitors in psoriatic arthritis and JAK inhibitors. They are also very useful for refractory arthritis. Exercise and physiotherapy, they are very, very essential. Smoking cessation is almost very, very helpful. It's a very critical one. So monitor with the regular monitoring and treat the comorbidities. Thank you.